on how advances in veterinary medicine can lead to advances in trauma patient care was first presented at the Trauma, Critical Care, and Acute Care Surgery Conference in Las Vegas in April of 2019. And I am Kelly Hall. I have no financial disclosures. And while I am the voice describing the breadth of work that has and will be accomplished, the Veterinary Trauma Initiative represents a large team effort with many players and contributors. The ACVEC is the specialty college that certifies specialists in veterinary emergency and critical care. This is the college within which the Veterinary Committee on Trauma was established with a vision to improve trauma patient care through clinical and translational research. Veterinary trauma centers are large, multi-specialty hospitals that provide the clinical laboratory in which the goals of the initiative can be carried out. Like surface puncture wounds in a small dog attacked by a larger dog that requires further surgical exploration, today's presentation only touches on the surface, and I'm hopeful to prompt ongoing conversation. While BDLD may not be an effective translational model, today I hope to convince you of the opportunities to leverage veterinary medicine to improve both veterinary and human trauma patient care. We'll start by exploring what naturally occurring canine models are, and then describe the similarities and differences between canine and human trauma injury, as well as the resources available to support the utilization of spontaneous canine trauma in translational medicine. Spontaneous, naturally occurring, or accidental refers to disease or injury that occurs in our companions. These are animals that live and work with us. Advantages in this population of animals include the presence of well-established breed lines that can lead to investigation of genotype and epigenetic causes of disease, and shorter life expectancies, which allow for more rapid evaluation of chronic disease as well as long-term impacts of acute injury or disease. Naturally occurring disease or injury refers to disease or injury that occurs in the lifespan of our companion animals. It is not induced experimentally in laboratory animals. As an example, Major, a Roseville, Minnesota police dog, was treated at the University of Minnesota Veterinary Medical Center for multiple stab wounds sustained in the line of duty. On presentation, Major was in hemorrhagic shock with a pneumothorax and rear limb paresis. He was stabilized in the ER with blood product and thoracocentesis, followed shortly by CT and thoracotomy. After performing MRI, a hemilaminectomy was performed to relieve his bruised, non-severed cord. Despite 2 weeks of hospitalization in the ICU, stem cell therapy, and physical therapy, Major never fully regained function to his rear limbs and was fitted with a wheelchair and retired from the police force. Major and his partner John went on to advocate for harsher penalties and is now a felony in Minnesota to injure a working dog in the line of duty. The concept of utilizing naturally occurring disease in companion animals is not a new one. A 2015 Science article highlights a variety of neoplastic, musculoskeletal, genetic, ocular, and cardiovascular diseases in companion animals with translational potential. Of these, the veterinary oncologists have gained the most ground investigating rare human cancers that occur more frequently in veterinary patients, as well as investigating interventions for diagnosing and treating a variety of cancers. At Colorado State University, a collaborative group of veterinary and human oncologists are investigating losartan for the treatment of osteosarcoma in pediatric patients after finding evidence of its benefit in naturally occurring canine osteosarcoma. Dr. Elizabeth Pluhar at the University of Minnesota has developed a highly successful vaccine therapy for meningioma and glioma in veterinary patients that has moved to clinical trials in people. When it comes to trauma, an animal model, whether induced or naturally occurring, must closely reapproximate the clinical scenario of severe traumatic hemorrhagic shock plus combined injuries, including source of injury, the body's response to injury, and ability to evaluate long-term outcomes. There are many preclinical induced large animal models of traumatic injury. True or false? Dogs are currently used in preclinical trauma models. This is true. Some more recent examples include a canine lethal hemorrhage and reperfusion model to further investigate age of red blood cell effects on clinical course and outcome, and the evaluation of emergency preservation and resuscitation in cardiac arrest due to prolonged lethal hemorrhage. I had the opportunity to see this research presented at an SCCM conference and was floored by the videos that showed before and after neurologically and behaviorally intact dogs in the EPR2 group. This research has moved to human clinical trials, initially enrolling in Pittsburgh, then expanding to Baltimore. I use this example to highlight the fact that dog models are already successfully used in efforts to improve trauma patient outcome. In fact, a spin-off of this research is investigating neuroprotective agents, a step that I argue could be investigated in veterinary clinical trials, as brain injury is an area of significant prevalence and interest in veterinary clinical patients. For example, this study evaluated the frequency of post-traumatic epilepsy in canine trauma patients and canine patients with seizures. 6.6% of trauma patients with evidence of head injury developed post-traumatic epilepsy, which increased to 14.3% when the patient had evidence of a skull fracture. Group 2 included patients presenting to the hospital for seizure activity, of which 15.5% had a history of head injury. This article urges the utilization of naturally occurring canine trauma as a model for post-traumatic epilepsy. I have presented evidence to support the utilization of spontaneous animal models. They provide opportunity to leverage resources and provide information to make go-no-go decisions as new drugs and devices are evaluated to improve the human condition. Those promising therapies and devices that prove beneficial can also be utilized by veterinary clinicians to improve care in veterinary patients. With a better understanding of what naturally occurring canine models are, what do we know specifically about canine trauma, and what are some manifestations that could be used as models to investigate methods to improve trauma patient outcome? Canine trauma accounts for more than 1 in 10 cases admitted to the ICUs of large, multi-specialty tertiary care veterinary hospitals. Banfield, a national corporate primary care group, reported that over 1/3 of cases presenting to their hospitals for emergency visits were due to traumatic injuries. In addition to high frequency of occurrence, trauma is also a leading cause of death in canine patients. VetCompass UK, a large database gathering information from primary care hospitals in the United Kingdom, recently reported that car accidents were the 3rd leading cause of death in dogs. Given that car accidents make up approximately 20% of all canine trauma cases, I'd be curious to see where this data point lies when all causes of trauma are included. In a U.S. university hospital database, trauma is reported to be the 2nd leading cause of death in dogs, second only to infectious causes for dogs less than 1 year of age, and to cancer for dogs greater than 1 year of age. Reported survivals to discharge for all comers is 85 to 92%. However, severely injured and polytrauma patients' survival to discharge rates drop to less than 50%. It is this population where opportunities for improving outcomes for both veterinary and human trauma patients exists. With that in mind, the Veterinary Committee on Trauma was established with a vision to create a network of lead hospitals that would work collaboratively to define and deliver high standards of care to trauma patients, as well as create, analyze, and disseminate information to improve trauma patient management and outcome. In addition to being the physical laboratory that houses the canine trauma model, these hospitals deliver exceptional care to all patients. In 2013, the first 9 veterinary trauma centers were identified, and a veterinary trauma registry was initiated. Today, the Veterinary Trauma Center network includes large, multi-specialty hospitals in the US, UK, and Canada that were initially identified, then subsequently verified as either Level 1, Level 2, or Level 3, based on resources available as outlined in a document similar to the Human Medicine's Orange Book. Level 1 hospitals must have a robust 24/7, 365 emergency and critical care team. A blood donor program, neuro, soft tissue, and orthopedic surgical specialists and supporting resources, including rehabilitation, are also required. Specialists in anesthesia, neurology, ophthalmology, cardiology, internal medicine, and medical imaging with varied response times to the bedside of the trauma patient are also required. While it has not yet become a requirement, the newly updated resources document strongly encourages a licensed social worker on staff, given the complexities of the human-animal bond. All veterinary trauma centers are required to have a performance improvement program and to enter information on all trauma cases presenting to their hospital into the trauma registry. For those interested, the 2nd edition Resources for the Optimal Care of the Injured Veterinary Patient is available on the VetCOT website. The primary aim of the VetCOT initiative is to improve trauma patient care. We aim to accomplish this by developing pathways and tools to enhance research collaborations, creating mechanisms for sharing discoveries, and elevating the visibility of the capabilities of veterinary specialists as an extension of the primary care veterinary team. The Veterinary Trauma Registry is housed in REDCap, a web-based intuitive data capture system available through CTSA grants. This system gives hospitals continual access to utilize their local data to inform their process improvement program. Pooled data is then available to help determine what injuries have best potential for translational medicine application and assist in designing clinical and preclinical trials. To date, the Veterinary Trauma Registry has over 37,000 dog and cat trauma cases and is growing rapidly as the network expands. The tables here represent data on the first 21,000 cases, of which just over 17,000 are dogs. Blunt and penetrating trauma make up relatively similar proportions. Struck by vehicle and fall from height make up a majority of blunt traumas, while bite wounds make up a majority of penetrating injuries. But as you can see, gunshot wounds, impalement, and foreign object lacerations are also present. Approximately 1 in 5 cases sustain injuries severe enough to require hospitalization in the ICU, which includes a population of traumatic hemorrhagic shock patients, an area with potential for translational research applications. Head injury also represents an area with significant translational potential. Just over 10% of cases have evidence of head injury, while approximately 6% have evidence of spinal injury. Not quite half of the patients have one or more surgical procedures performed, with approximately 2/3 of surgical procedures happening in the ER versus the OR. The trauma registry population includes all comers, with an overall very low median injury severity score and exceptional survival to discharge. That said, this large data set presents opportunity for further investigation of the more severely injured populations, including those that have died due to their injuries. Similarities in human and canine trauma patients includes the fact that younger animals are more likely to sustain injury, with a second spike in geriatric animals. Additionally, with populations of both intact and neutered animals, possible causes of survival advantage between the sexes could be further investigated. While the distribution of mechanism of injury differs, patterns of injury are similar, as are manifestations of the body's response to injury. Validated injury severity scores exist for application in clinical trials and outcome research. Differences include availability of pre-hospital care, although there are efforts to expand this in veterinary medicine. While time from injury to hospital arrival in veterinary patients can vary, there is a large portion that arrive within 30 minutes of their injury. Additionally, populations that take longer to get to definitive care facilities may help model some of the challenges present in rural trauma patient care. While euthanasia is certainly a factor that cannot be ignored in veterinary medicine, enrollment in clinical trials that may defray costs of hospital fees may encourage owners to move forward with treatment, an effect realized in oncology translational research studies. While there are differences in resources available to the trauma patient in veterinary versus human hospitals, the extent of resources available in veterinary trauma centers is beyond what is perceived by many in the medical field. Finally, naturally occurring canine trauma allows for a model that is more similar to the clinical manifestation of human trauma, including the ability to evaluate long-term outcomes in patients that have sustained injury without concurrent general anesthesia. Clinical research and trials using this model can be cost-effective when compared to preclinical and/or phase 1 and 2 clinical trials, and can be used to inform go-no-go decisions on the drug and device development pathway. I propose to you that naturally occurring trauma in dogs can serve as a translational model to investigate mechanisms to improve trauma patient care, with traumatic brain injury and acute traumatic hemorrhage and coagulopathy representing two manifestations with significant potential. Over the last 5 years, a multidisciplinary, multi-institutional group has put infrastructure in place to help design and execute clinical research and trials, including the Veterinary Trauma Center Network and Trauma Registry. Finally, a group of university-based hospitals, of which 6 are in the Veterinary Trauma Center Network, have established in-house clinical research groups trained to implement multi-institutional trials. In addition to the VetCOT and Veterinary Trauma Center teams, I would like to thank Dr. Greg Bielman, who served as my clinical research master's advisor, and I am ever grateful for his support and not laughing me out of his office when I introduced myself as a veterinarian looking to improve both veterinary and human trauma patient outcomes. Thank you.